So what we are going to do is go into the meat of the, so we'll hold off the questions at this point, go into the meat of the conference. And the first speaker would be Jennifer Dietrich. And she is, as I said, a pediatric gynecologist at Baylor College of Medicine in Houston, Texas. And Jennifer is going to talk about managing acute menorrhagia in adolescents with bleeding disorder.
Thank you. Can you all hear me okay back there? All right, well, I really appreciate the opportunity to be here this morning, and it's nice to also see some familiar faces in the audience. So just as part of what I am supposed to do, my disclosures, primarily related to research and medical advisory work, I really want to address two basic objectives today. And so for this morning, I want us to review the impact of acute menorrhagia in adolescents and young women. I would also like to review the evaluation and management of acute menorrhagia. So it's first important for us to define menorrhagia. What is it exactly? Well, we do know that it's a key vital sign in the assessment of menstrual problems in young women and adolescent girls. And menorrhagia is technically defined as greater than 80 mLs of blood loss per menstrual cycle, bleeding lasting more than 7 days, use of more than 3 to 6 pads or tampons today, passing clots that are greater than 1 inch in diameter, and soaking clothing or bedding. And so when these things are present, it really should heighten your suspicion for possibly a problem in this young adolescent female. So how do we differentiate in the acute setting? We're really talking about the adolescent patient who presents to the emergency room with severe, heavy menstrual bleeding, to the point where we're really considering an admission to the hospital. And so this is an excessive intermenstrual bleeding occurring in a woman of childbearing age requiring emergency treatment. We have to first exclude pregnancy, the possibility that's related to postpartum hemorrhage, trauma, or malignancy. And then finally, it's bleeding resulting in an anemia or low serum ferritin level. So I have to thank one of my fellows actually for providing this picture. But this is sort of an artistic depiction of an adolescent female's nightmare, okay, when she's dealing with acute menorrhagia, especially at the time of menarche. And so unanticipated heavy bleeding may be frightening for patients, may be frightening for families, and when they describe heavy bleeding, this is what they're dealing with. This is what they're dealing with when they present to us in the emergency setting. So a brief look at statistics also reveals a worldwide impact. And among adolescents with menorrhagia, prevalence estimates range 5 to 36% for one milligram disease, 2 to 44% for platelet dysfunction, depending on the studies that you read, up to 8% for clotting factor deficiencies, 13 to 20% for thrombocytopenias. So the evaluation for this condition may seem straightforward. There is no question that we want to take a good history. We want to do a good physical exam, especially since sometimes history will provide clues to the underlying diagnosis and ultimately allow us to choose the best treatment options for our patients. It is imperative that we rule out pregnancy in this population and/or infection, because the reality of the matter is that we're dealing with a population of patients who may be engaging in high-risk activities. They are a sexually active group. And in looking at some of the CDC statistics with regard to high-risk activities in adolescents, the unfortunate reality is that about 7% of females are sexually active under the age of 13. So it's a question we must ask. So we're going to take a good history. We're going to do a good physical exam. We're going to assess their vital signs to determine if they are hemodynamically stable or not. Depending on the age of your patient, a speculum and/or a pelvic exam may be necessary or may not be necessary. Laboratory evaluation will be important, and then certainly imaging studies can help us guide whether or not there's an anatomic problem as a result of their bleeding. So I won't belabor the lab evaluation because you all are well aware of what may be involved in a patient who presents with a bleeding challenge. But I wanted to give you a sense of how a gynecologist might approach initial testing. If we sort of focus on the first tier, gynecologists will be very comfortable sending a pregnancy test, sending a complete blood count. They may feel comfortable sending initial coagulation studies, as well as an iron profile and a thyroid panel. However, depending on the gynecologist's level of comfort, they may or may not feel comfortable sending a von Willebrand panel, and this may be an opportunity for them to reach out to you as hematologists to work together to manage a patient. If those tests are sent initially by an OBGYN, it's still an opportunity to touch base with our hematology colleagues, as certainly these patients may ultimately need further testing. And certainly when we get into the second tier of evaluation and laboratory evaluation, we are going to be reaching out to our hematology colleagues to co-manage patients for whom we are concerned may have an underlying bleeding dyscrasia. So as you are all well aware, tests are not perfect, and a variety of conditions or medications can certainly affect the results' accuracy. And so estrogen exposure is really no different. So for instance, if we're looking at estrogen effects, dose response matters. Higher concentrations might interfere with certain assays. We know that there is an upregulation of platelet binding factor production and an increase even in von Willebrand factor production as a result of estrogen exposure. Concentrations of estrogen are certainly magnified in pregnancy as well. And then there are other factors that go into play. Plasma volume expands, there's an increase in erythrocyte mass, an increase in fibrinogen, and other factors in the coagulation cascade. And so how do we avoid some of these estrogen-related effects? Well, we can consider testing in someone that we are concerned about an underlying bleeding problem in the postpartum period, for somebody who may have had a challenge during the immediate postpartum period or during pregnancy. For accuracy and for confirmation, ultimately. We want to avoid peak time of estrogen secretion during the menstrual cycle. So consider testing rather than throughout the menstrual cycle or at a random time during the menstrual cycle. Consider testing days 1 through 4 of the menstrual cycle when your estrogen concentrations are lowest. And if a patient has already been placed on a combination hormone pill, consider testing during a placebo week, because once again, this is the time frame when estrogen concentrations are lowest. Furthermore, gynecologists don't commonly think of thyroid problems affecting coagulation factors, but you all are well aware that there are many things that do affect some of these assays when we are attempting to confirm whether or not somebody potentially has an underlying bleeding problem. So for instance, thyroid stimulating hormone, something we commonly see as gynecologists in association with hypothyroidism, resulting in heavy dysfunctional uterine bleeding. Well, it actually decreases von Willebrand factor. You all know that. You're well aware of that. But not all gynecologists are, and so it's an ongoing discussion about the fact that these are needed tests to help interpret coagulation tests to some degree. So finally, we can't have a talk without some sort of a pediatric cartoon, right? I know that a lot of the kiddos at the Children's Hospital kind of respond better and learn if you put things into their context. But certainly, despite our best efforts in the setting of acute menorrhagia, tests are ultimately going to need to be repeated. And so in the setting of stress, your von Willebrand factor is going to increase. It could falsely elevate into a normal range. And so for us as gynecologists, it's important for us to recognize that still it's important for us to reach out to you all as hematologists. Ultimately, this patient is going to need follow-up, is going to need further testing to determine if a bleeding disorder is present or not. Well, until recently, Some OBGYNs have not considered bleeding disorder screening in patients presenting with acute menorrhagia, primarily because adolescence, it's a particular time of life when anovulatory bleeding is very common. It may happen in 50 to 90% of young girls at some point within the first 3 years of menarche. However, in one model, this Markov 20-year decision model, it actually looked at whether or not this was cost effective. And so in this population they studied, the prevalence of von Willebrand disease in adolescents was estimated at 13%. And what they found is that screening for von Willebrand disease had an incremental cost effectiveness of about $62 quality adjusted life years before starting an oral contraceptive pill. And the reason is that, sometimes we may need to add a hormone in order to control an acute menorrhagia episode. Nonetheless, it happens to be cost effective to screen the patient prior to medication administration, because we do know that estrogen will affect those results, and estrogen can mask an underlying mild bleeding condition. And so it gives us information and strong evidence that really it's worthwhile doing the screening. Well, let's move on to discuss management a little bit. So in addressing uterine bleeding problems, gynecologists have several goals in mind. So number one, we want to maintain fertility. We definitely want to treat early to prevent multiple blood transfusions. We want to prevent serious admissions to the hospital. And we really would like to avoid a dilation and curettage or a DNC, except in cases of absolute emergency due to associated risks. And then finally, we want to work with our hematology colleagues to correct any underlying hemostatic deficiencies if present. So we can categorize acute management as follows. We have several first-line options, second-line options, and then maintenance therapies. In the acute setting, most gynecologists are very comfortable with hormonal management. And given the newer data supporting use of antifibrinolytics for menorrhagia, the comfort level is increasing in this area as well. Finally, if we are concerned enough and patients aren't responding to first-line medications, we can also consider mechanical options. A mechanical option that seems to work quite well in adolescents is balloon tamponade. And so just to give you a feeling for how that works, essentially a 30 cc Foley balloon works very well, is the perfect volume for an adolescent uterus as a tamponade device. It can be placed for 24 hours and then easily removed for additional mechanical tamponade effect. Now in the second line category, due to significant risks of thrombosis with factor VII administration, gynecologists would not initiate such a treatment for menorrhagia without specifically consulting with a hematologist. Nonetheless, we want to exhaust all medical and non-invasive options since surgical interventions can come with risks. And so these are typically avoided if possible. And so some of the problems that we see with dilation and curettage in the young patient population is permanent scarring, okay, that can ultimately result in infertility. We call this condition Asherman syndrome. And endometrial ablation. For those of you who may be familiar with this, this happens to be a variety of different techniques that essentially sort of ablates or decreases the thickness of the endometrial lining within the uterus. There are a variety of different techniques in which to do this, some of which involve cautery, some of which may involve cryotherapy or heat ablation. They all work toward the same goal, to decrease the thickness of the endometrial lining and decrease bleeding effects. But it's really designed for the woman who's completed her childbearing years. We don't yet know what effects this might have on an adolescent female long term, but there has been some concern that certainly there could be abnormal placentation later on, scarring, and Asherman type effects. And then certainly hysterectomy, we have a lot of different ways in which we can accomplish this in women, including minimally invasive options nowadays, but it's absolutely a last resort, especially in the adolescent female. So keeping these factors in mind, I want to just drive home the message that really in the adolescent, fertility, maintaining fertility is critical, and hysterectomy in this population is not an option. Hormones are definitely the first line of defense, and if a bleeding disorder is known, working together, gynecologists and hematologists, may be important for management, okay? Hormones may be needed in addition to hematologic agents. And if a bleeding disorder is not known, it's still a perfect opportunity for us to work together, ultimately to achieve a similar goal in this female. And then finally, we have some mechanical options that are reversible. So if we need to use something such as balloon tamponade, it's very easy for us to work together with you all if you have a challenging bleeding patient. I think a perfect example of this happens to be possibly a young female who is diagnosed with a bleeding disorder prior to menarche. Maybe that was known, or maybe it was an inherited condition. But at the time of menarche, a bleeding challenge presents itself again. And that patient may already be known to the hematology service, but may not yet be known to the gynecology service. Certainly, we always welcome the opportunity to work and reach a common goal if a mechanical option is needed in addition to medications. So when acute management has been successful, transition to a maintenance therapy is important. And ultimately, the goal is to transition to a home regimen that the patient can adhere to, and which really minimizes side effects. Of course, we want to choose something that is going to be effective for the adolescent female. Not all adolescents are the same, and so some may be able to adhere to a daily regimen. Others may need something creative, or a different option which enhances their ability to comply with therapy. And ultimately, we want to reach the goal of allowing them to transition to having controlled cycles and minimizing breakthrough bleeding episodes that are heavy and bring them into the hospital. So let's take the case of an adolescent female. Let's say she's 13 years old and she presents with menorrhagia. Maybe she's known to your service, or maybe she's known to the gynecology service. In the gynecology setting, however, if the diagnosis is not made, this is sort of a roadmap of how a gynecologist may approach the initial acute bleed. And so this is sort of what we may approach as a first line in terms of laboratory evaluation. We're certainly going to rule out pregnancy in any situation in a reproductive age female. Gynecologists may send some of the initial tests in addition to a von Willebrand panel. If there's a concern about the heaviness of bleeding or the hemodynamic stability of the patient, hormones are going to be the first line choice. This may be given in an oral route or an IV route, and depending on the adolescent's ability to tolerate oral intake, this is how we make our decision about which therapy is best. We may ultimately get an ultrasound to rule out that there is any other anatomic problem resulting in heavy dysfunctional bleeding. And if the bleeding stops, many gynecologists will then slow taper to an oral regimen that they can then take at home. And when the bleeding continues, this is when we are reaching out to our hematology colleagues, and our suspicion is heightened for an underlying bleeding dyscrasia. So our management is not only guided by the previously discussed goals, but also by presentation, hemodynamic stability, and the presence of mild or severe anemia. And so really this table is just demonstrating how in the mild category, it's something that we want to be attuned with, but sometimes it's a matter of reassurance, education, possibly some initial outpatient workup, but doesn't necessarily require an admission to the hospital. all the way down to the category of hypovolemic shock. And if we're considering and facing severe anemia states, we really want to make sure that we are stabilizing the patient, that we're ruling out coagulopathy. And these are the patients that certainly if bleeding is a continued challenge, may be in and out of the hospital for blood products or transfusions. This is exactly what we want to prevent. So some of you may be familiar with hormonal agents utilized for acute menorrhagia. But for instance, many gynecologists in the setting where an adolescent cannot tolerate an oral regimen may choose an IV hormone formulation. So the most common IV formulation happens to be an IV estrogen, which can be given every 6 hours. Alternatively, we can use a high-dose combined oral contraceptive pill that really kind of results in the same bioavailability and the same effects in terms of administration of an IV formulation. And so it can also be administered every 6 hours. There are a lot of different taper protocols, and a lot of these protocols exist in the literature, but ultimately we want for patients to adhere to the plan so they don't have a repeat bleeding episode. Not all individuals may be candidates for estrogens, so we have to keep this in mind as well. Unfortunately, there are several options that we have in the acute setting for management. So we can use progestin-only medications as well. So at least in the progestin category, we can use things like norethindrone acetate or medroxyprogesterone tablets. These can be tapered in a variety of protocols. There are a lot of different doses available and maximum doses as well to ultimately achieve the desired effect. And so in a patient who might have both a bleeding and a clotting problem, this is the ideal choice for that patient. Well, some patients actually pose further challenges, and we have some institutional experience with this, and this is sort of our anecdotal experience at Baylor. We've had 4 patients in our practice, all with symptomatic menorrhagia, all ultimately diagnosed with underlying bleeding disorders. 2 ultimately were diagnosed with a von Willebrand disease type 1, and 2 were diagnosed with platelet function defects. They had poor response to pills and other methods they had tried in the outpatient setting. They had a lot of side effects related to nausea and emesis with pills, and then they simply declined taking pills or other methods that they had previously tried that they felt did not work for them. And so they wanted to try something different. And so what we did for these patients is that we offered a creative taper. And so in the alternative taper strategy, what was done for these patients is that they were given a combination patch and a combination ring for 7 days. Bleeding stopped within 24 to 48 hours in all cases. The combination patch was then continued 7 days later, and the ring was removed from the vagina. After 7 days of just the patch was then removed and the ring was replaced. So this worked very effectively for these 4 patients. And sometimes we have to think outside the box depending on the patient presentation. So none of our patients fortunately experienced any problems with this type of regimen. Nobody had repeat breakthrough bleeding. And in terms of side effects, no side effects were demonstrated in terms of thrombotic events or other problems. Now, we sort of teach our patients about a little mnemonic anytime anyone is given a combination oral contraceptive pill or a combination option. And so ACE stands for abdominal pain, chest pain, headaches, eye symptoms, or severe leg pain. And so we sort of teach them about this, and they declined experiencing any of the symptoms. So we frequently work with our pediatric hematology colleagues when antifibrinolytics are necessary, either as a standalone medication or as an addition to hormonal treatment. And so whether tranexamic acid or aminocaproic acid is chosen, we have a variety of different options. Route of administration may be guided by patients' ability to tolerate medication, whether or not they may be undergoing procedures in the operating room, and certainly whether we're doing this in the inpatient or the outpatient setting. So a variety of clinical trials have assessed the efficacy of tranexamic acid in blood loss reduction. And really the common theme that I want you to take home here is that it demonstrates uniformly a reduction, though the percent varies slightly from study to study. And this happens to demonstrate a reduction in the mean menstrual blood loss in women without bleeding disorders. However, it's also been demonstrated in women with bleeding disorders. Mean reduction in menstrual blood loss is significant. And so in summary today, I just want to reiterate that menorrhagia is common among adolescents. Acute menorrhagia may be managed with a variety of hormonal options. Non-hormonal options are also useful in treating menorrhagia. And acute severe menorrhagia may be the sign of an underlying bleeding disorder. So it's something that we want to think about as obstetrician gynecologists and moving forward in the patient who presents with heavy bleeding at menarche. But really heavy bleeding at any point in their life is something of concern to us. And then when there's a patient with an underlying bleeding disorder that may be known to the hematology service, it may be helpful to reach out to your gynecology colleagues if you feel a hormonal addition may be of benefit in the acute setting. And so I'm happy to take any of your questions. I thank you for your attention today. And that's it.
Thank you very much, Jennifer, for this excellent talk. And this is open for any questions. Please come to the microphones which are situated here and identify yourself and your institution. Thank you very much.
My name is Matzdorf. I'm from Germany. Actually, this was a very good presentation. I liked it because I see a lot of women with bleeding disorders, but I'm kind of concerned about the inflated use of the term von Willebrand's disease, which is a inherited disorders and requires counseling of the family and all these problems. In many cases, it's just blood group 0, and these patients have low blood von Willebrand factor levels, and they have not a familial disorder. Did you people work out how many of your 13% von Willebrand disease people are really von Willebrand disease, where you need to counsel family, or is this just 99% blood group 0?
So I think that that's a very good question, and I know that at our center at Baylor, I happen to be very, very fortunate and co-direct a clinic with Dr. Lakshmi Venkateswaran at the Texas Children's Hospital, and we together put our heads together about certain patients, and certainly there are patients in which it's easy or easier for our hematology folks to confirm whether or not a patient has a von Willebrand condition. But because of a variety of other factors that go into play and ultimately may delay diagnosis, there are some patients that we may not be able to confirm a type 1, type 2, or type 3, but may just demonstrate low activity. And so it is very challenging, very challenging.
Peter Quitas. Jennifer, thank you. That was a very good presentation. The patient who has acute menorrhagia, who is morbidly obese, theoretically there's greater concern for thrombosis. Do you decrease your dose of estrogen exposure or duration?
So really, that's a great question. So the question is, should you decrease your dose of estrogen based on an obese patient? So, the reality of the matter is that we are dealing with childhood obesity much, much more frequently, and so we do see it. However, in the acute setting, because we are administering these high doses for a brief amount of time, it has not been demonstrated that you need to change your dose or alter your dose because it's such a brief administration, nor have we seen any increased events of thrombosis. And so even for some patients who may not respond as well to progestin therapies, it's been determined that a short or brief course of estrogen does not seem to increase their risk.
We have a question in the back.
Yes.
Lakshmi Venkateshwaran from Texas Children's Hospital, Houston, Texas. First of all, I want to thank Dr. Kulkarni and Jennifer Dietrich for an excellent presentation. I think it's a great start for the ASH meeting. Question is for Dr. Kulkarni. I'm just curious to find out, as part of your female UDC project, if you came across a subset of patients with fibrinolytic pathway defects, because I think in the era of better oral antifibrinolytic agents, if we don't test at least some of those patients with severe menorrhagia, I wonder if we might miss the diagnosis.
That's a very good question. And in our UDC surveillance project, we recorded what was reported by the hematologist at the institution. If I recall, I will have to go back and look at the database to see how many. There probably were not very many, because the numbers diminished after the von Willebrand's and all this. But clearly you bring up a very important point about, as I tell my residents and fellows and all, to test the patient beyond the APTT. Because everybody does PT, APTT, and von Willebrand, and they stop there, and they never look beyond that, look at PI1 and things like that. And we should be doing those, especially in those women who have quote-unquote non-von Willebrand menorrhagia. So I think you bring up a very, very good point.
You just answered my question. What I was going to ask was, in your patient that has a normal PTT and normal platelet functional assays, do you check them for von Willebrand's anyway? So I guess you answered that. You said you did.
Yes, we do.
Meera Chitler from Children's Hospital of Michigan. Thank you, Dr. Dietrich. That was a wonderful talk. Thank you, Dr. Kulkarni. Yours was great, too. I have a question regarding a kid that's on a birth control pill already. Is 1 week sufficient time for the estrogen levels to come down and to baseline to check for von Willebrand's disease again? Would you check just prior to the start of the next period? Or how would you tailor?
Sure. So that's a great question. So, the nice thing about a pill, and the reason we are very strict with our adolescents about compliance, is that really, technically, oral contraceptive pills have a half-life of 24 hours. And so, while desired effects in terms of, certain studies, if we're really kind of controlling those factors for a birth control pill, we say a washout period of 3 months is really desired. But you really do decrease your ethinyl estradiol levels significantly because the half-life is so short, and so it's adequate to test them during the placebo week. Because of other factors that may be involved with a variety of assays, stress, thyroid conditions, blood type, those factors could also impact your ability to make a diagnosis, and so it's possible you'll have to repeat the test regardless.